My name is Jeff Bauer, and I own Leisure Time Sports Bar and Bowl here in Prairie du Chien. I've been pretty inactive the last 6 months because of my hip problems that I've had going on.
Jeff, when he first came to me, was walking with a significant limp.
It's been a gradual thing, probably the last year. With the last 3 months, the pain got severe, so I'm able to walk now with a cane only. Without one, I can't take a step.
Had constant pain in his hip with any weight-bearing activity. So things that he normally enjoyed doing, bowling.
I love to golf, love to walk, all of which I've not been able to do any of for the last 6 months, which has really been discouraging.
He had that progressively worsening pain within that hip. It was starting to slow him down. He was no longer able to do the things that he enjoyed doing. He was having a significant change in his quality of life.
I'd like to be able to keep up with my wife, Sherry, for one thing.
And we had tried multiple different options from a non-operative standpoint. But despite all those things, initially we had some relief with medications, but as the arthritis within the hip became more severe and progressed, then he developed more symptomatology. And once he got to that point, then no matter what we were doing, he was in just in significant pain and was at the point where he's like, hey, I can't do this anymore.
That's to the point now where it's just bone on bone and it's time to get a new hip. 6 a.m. tomorrow, a little nervous, but it'd be nice to get my life back to normal too. So many things you miss out on. Pain is so constant. You know, it's a scale of 1 to 10. The pain's usually a 7 no matter what I do anymore. So the surgery can't come quick enough. I'm really excited to get it done.
For the day of surgery, we have the patient come in about an hour and a half to 2 hours before the surgery itself. Then we have the patient go up to the surgery area. They are met by one of the nurses and our staff there. They get asked a bunch of questions regarding their medical history and things like that too. Even though that's known, we always confirm everything in terms of medications, things like that. The IV is placed. And once we have everything all set ready to go, I go in and talk with the patient again. We go over everything from A to Z. We talk about risks and complications. We talk about the surgery itself. And then we actually confirm what we're doing for them that day. That would be the side that we're working on and the procedure that we're doing. Even though we've talked about it multiple times, we actually still confirm that day, and then we mark that side. All right, so we're just gonna mark this side so everyone knows, and we agree again, right side is the correct side.
Got it.
Okay, perfect. Surgery itself will take about 2.5 hours or so. Okay, it could take a little bit longer, a little bit shorter, just depends on what we see when we get in there. And then once we're all set ready to go, and the room is ready, we wheel the patient back.
Sure, go ahead.
Thanks for loving me the way you do. Just going to be nice to get it fixed, where I can be active again and have some fun and do the things that I really like to do. I'm ready to go.
First thing that we do is obviously we provide the anesthetic. They start there first, and then once we have them anesthetized for the procedure, then we go through positioning to make sure everything's well padded for the patient. Because remember, they're going to be laying there for a period of time. We want to make sure that everything's relaxed comfortably. We're not going to put any stress across anyone's joints, or they're not going to have a pressure area where they've been laying for an extended period of time. So make sure everything's really well padded.
We get that patient prepped and draped. The circulating nurse kind of moves about in the room the entire time during the procedure, helping to make sure that supplies are all available and accessible. The surgical tech is in the room the whole time, maintaining the trays and the equipment that Dr. Klean is going to need during that procedure. Myself, I'm acting as a first assist during that, so that I'm helping with retraction to make sure he has good visualization, helping with tool and equipment management to make sure things are flowing smoothly.
If we're doing a total hip replacement, like we were doing for Jeff, we actually bring the C-arm, which is real-time X-ray, and we take a look, make sure that we get the appropriate images that we're looking for, and make sure that the pelvis is appropriately aligned and we can trust the pictures that we're looking at. The initial part of the procedure is make an incision in the skin. I do the anterior approach, or the direct anterior approach, which is a minimally invasive procedure, not because the incision's any smaller, but because it's soft tissue sparing, okay? What that means is we don't cut through any muscles, tendons, or ligaments. We actually dissect down through those planes and we move those out of the way, so we're not cutting through those structures. That decreases postoperative pain and bleeding, which is something that we're trying to avoid as much as possible, so this approach allows us to do that. There's a ball that connects to the neck, and then the femur goes all the way down to the knee here, and then it has a cup within the pelvis, and that makes up our hip joint. So what we do is we actually open up this capsule, kind of like this. We've actually cut right across the neck, and we get rid of the head. And we remove those because they're worn out. They're not going to help us any longer. After that, it kind of looks like this. After we cut the head and the neck, we get that out of the way, we're actually able to work our way to the cup side. Initially, we ream, or we take out all of the arthritic, sclerotic bone inside of the acetabulum or the cup, get it down a nice healing bleeding bone, and then we actually impact the appropriately sized cup into that acetabulum or the cup. Now we have this where we've cut off the head and the neck. What we do is we actually take a stem that looks very similar to this, okay? It has this nice gritty coating over the top of the stem that allows for the bone to actually grow onto the stem over time. It goes down inside the femur, just like this. So that's what it looks like inside the bone once we address the femoral side. Then we've got to put a new ball in place, right? So what we do is I actually use what's called a dual mobility or a double mobility articulation. So you actually have a ball inside of a ball, which increases our stability and also improves longevity or the wear properties. So once we're done, once we reduce the hip, this is what it looks like when we're done. And now we've made a nice smooth bearing surface, which significantly decreases the amount of pain that we had from the arthritis that was there before. We trial that a couple times to make sure it has appropriate stability. We test that throughout range of motion and test for appropriate stability. And once we're satisfied that we've got a well-sized acetabular component, we've got a well-sized femoral component, and we've got the appropriate offset and length based on our implants, then at that point we put in the final implant. We take final pictures, again, real-time x-ray with that fluoroscopy, make sure that we like the position, the alignment, the offset, leg lengths on either side. And once we're happy with that and we retest our stability, we've got a nice stable hip. At that point, then we start our closure.
About 95% better already. No major pain pills anymore, just Tylenol, IV Tylenol. So that's made a big difference. But other than that, I'm getting up to walk. I'm going to the bathroom by myself. I mean, it sounds like those are all little things, but to me they're big, because I haven't been able to do any of that.
Every day he'll work with the therapist. We'll make sure his pain's controlled. We'll make sure all of his labs look okay. The medical doctor or the hospitals will see him, make sure that from a medical standpoint he's doing well.
They've been taking really good care of me.
If everything's progressing as expected, our goal is to get the patient home by about postoperative day number 2, sometimes postoperative day number 1, depending on how they're doing.
Well, I'll be back with a follow-up with Dr. Klean middle of next week, and then I'll be starting physical therapy in their department downstairs at some point next week.
We take repeat x-rays, make sure that things are progressing well, that their pain is adequately controlled, and they're able to independently and safely do the things that they need to do throughout the day.
Probably day number 5, I was able to not use the walker anymore, didn't have to use it anymore, and no pain meds other than a Tylenol for a few days after that.
At 6 weeks, most people are feeling pretty good, back to most normal activities. At 3 months, even better than that. It will take a full year to a year and a half to completely recover, but most people are feeling much better, especially with a lot of patients that we see that are debilitated with this. A lot of times, we take them through this big surgery, basically cutting out their old joint, putting in a new joint, and they actually feel better than they did before because of the amount of pain that they were in.
Man, I'm getting my life back, and it is just amazing. I mean, I'm able to walk now with the dogs. Sherry and I are getting out and about, and I went 3 months either on crutches or a cane where I was almost totally immobile. And then to come out of surgery, get up half an hour after surgery and be able to walk pain-free, other than the incision, honestly, it's amazing the job they did. I couldn't be happier.